I did my sleep study on October 26th. You sent me a WatchPAT sleep study, which is, it has 3 monitors, one on the wrist, one on the chest, and one on the fingertip. And I slept separate from my wife and baby. I came up here to my studio and I slept on a twin bed in the back, which is very comfortable, very silent, very peaceful. Because I know that if I were to have slept with my wife and baby, I would be waking up even more, you know. Um, and yeah, so this is what we got. We've got. Should we start here? Maybe.
Yeah, let's start here.
Okay. So yeah, why don't you just take it away and lead the way
Oh,
with it?
yeah, and then just chime in when you have when you want to comment. So it looks like you went to bed the start time around 9:25 p.m. You looks like you ended the recording at 6:20 a.m. So it recorded for about 9 hours, 8 hours and 55 minutes to be precise. And then the sleep time was calculated at 7 hours and 8 minutes. Now, usually we like 85% sleep efficiency in the lab. We like 90% or so at home, ideally. And so, you're about an hour and 40 minutes off of that, right? So maybe not the ideal, but a little bit less than we expected. Going into the respiratory indices, just for your viewership who may not know the terminology, I'll start from the bottom up. ODI 4%. The ODI stands for oxygen desaturation index, 4%. What that means is how many times did your oxygen level drop 4% or more during the night? And index I always means per hour. And that was 1.6. So you have to move your eyes to the right to the all night 1.6, that's in bold. So 1.6 times per an hour, your oxygen dropped 4% or more. The PAHI 4%, the P refers to the WatchPAT. The A refers to an apnea, which is a 90% or greater reduction in your breathing. And the H refers to a hypopnea, which is a 30% or greater reduction in breathing. And the I's index and the 4% means it had to have caused, the interruption in breathing had to have caused a 4% drop in oxygen. So, quick summary is Ron, using a WatchPAT, how many times did he completely or partially stop breathing per hour that caused a 4% drop in oxygen? Once again, 1.6 per hour. Usually the ODI 4% and the PHI 4% are similar in numbers. The PHIC 3%, that's just saying, okay, using a WatchPAT, how many times did Ron completely or partially stop breathing per hour? But it was that caused a 3% drop in oxygen, but it was due to a central apnea, meaning it came from the brain per se, right? Versus an obstruction in the throat. And that was 1.2 per hour. And usually that's under 5 per hour. The ODI 3% is exactly what you would think it would mean. It would mean that how many times did you have an oxygen drop per hour of 3% or greater? And obviously, you would expect that to be more than the 4% number, right? Because it takes fewer intensity events to drop it to 3%. And that was 5 per hour. And then the PHI 3% is using a WatchPAT. How many times did Ron completely or partially stop breathing per hour? That caused a 3% drop in oxygen. And once again, that's very similar to the ODI 3% at 5 per hour. And then finally, the PRDI is respiratory disturbance index using a WatchPAT. That basically says that subsumes the entire PHI 3%. It looks at how many times you had an interruption in breathing that caused a 3% drop in oxygen, but also an arousal. And with the WatchPAT, that arousal is based on sympathetic. It's a sympathetic arousal. It's looking at the arterial constriction in your finger as a correlate for an EEG cortical arousal. And that came out to 9 per hour. So the two numbers I always focus on are the top two rows, and the PRDI and the PHI 3%. If it's 0 to 5, it's considered normal. 5 to 15 is mild. 15 to 30 is moderate. And 30 and more is severe. So for you, your PHI 3% was 5 and your PRDI was 9, which is squarely in the lower half of the mild sleep apnea zone. So, based on just these numbers, we would call it mild sleep apnea, assuming you had some symptoms. Now, if I not scroll over, if I move over to the column under REM, you can see that in the same box, you can see that the 5.0 became 9.8 and the 9.0 became 15.8. And what it's showing is that in REM sleep, your airways relax, the skeletal muscles kind of, calm down. And if you have a compromised airway, it's more compromised during REM sleep. And sure enough, your 5 became 9.8 and your 9 became 15.8. And 0 to 5 is traditionally considered normal. 5 to 15 is mild. 15 to 30 is moderate. And 30 and above is severe in terms of severity. And so you became mild to borderline moderate during REM sleep. And
Interesting.
if your AHI 3% overall instead of 5 had been 4.9, for instance, or less, I would have, essentially called this upper airway resistance syndrome. It's, like as I said, I think once previously, when the AHI is kind of less than 5 and the RDI is greater than 5, that's more in line with, what we used to call upper airway resistance syndrome. Now, looking on the top.
You said in my podcast with you that the term that upper airway is resistance syndrome (UARS) doesn't technically exist anymore. Is that right? What did you mean when you said that?
Well, there's the International Classification of Sleep Disorders. They come out with their new edition, kind of like the DSM-1, DSM-2, DSM-3, 4, 5 in psychiatry. There's the ICSD 1, 2, and whatever. And in their last one, and the one before that, there was no upper airway resistance syndrome. It's all subsumed under the diagnosis of sleep apnea.
But
I think
then, uh, uh, but then, wouldn't it be not classified at all according to what you just said? If numbers less than 5, AHI 3%, you said that it would be considered UARS. But if UARS doesn't exist, then would I just be sent away by most other sleep doctors if I had scored 4.9 because UARS doesn't exist anymore?
no. Well, you shouldn't, because in the ICSD, in the International Classification of Sleep Disorders, a, RDI greater than 5 is considered abnormal.
Okay.
So as
Okay.
long as your RDI is greater than 5, you have sleep apnea. Assuming that the official rule is if it's between 5 and 15, the RDI, as long as you have symptoms. Well, my gosh, is it really that difficult to have symptoms of sleep apnea? It can pretty much cause
No.
anything. So
Right.
effectively, if your RDI is greater than 5, you have sleep apnea technically,
Okay.
which, yeah.
Please continue with your normal reading of this
Oh, okay.
analysis. Yeah.
And then we'll go.
I am marking down questions now as we go, but don't want to interrupt the flow of you kind of giving us the big picture.
Oh, okay, okay. Either way, the oxygen saturation stats on the box on the top right, the mean is 95%. That's great. I like a mean of 95, 96%. So your oxygenation is good, which tells me your lungs are good. In general, you can't oxygenate like that if your heart and lungs aren't working too well. Your minimum.
What's oxygen saturation in like a normal healthy person with a great airway as they go about their day for perspective?
Um, I think that's a loaded question. I think at night, I mean, sorry, during at night you want 95, 96%, ideally somewhere around that range. I think during the day, you could argue between 96 and 100%. The
Hmm.
problem is if it's close to 100%, you would think that's good, right? But that's actually not good. You could be overbreathing. Your
Mm.
CO2 could be low and you could be overbreathing. So technically, I think almost everyone would think that 100% oxygen would be great. But if you strap on the CO2 and the capnography and their CO2 is less than 35 millimeters of mercury, then it's too low.
So the definition of 100% is not the good or the normal. It's just, is it like 100% of the blood's ability to hold oxygen? What does 100% actually mean technically?
That's the saturation of the oxygen to the hemoglobin, but it doesn't necessarily mean how much oxygen is being dispensed to the tissues.
Right, because dispensing to the tissues depends on catalysts like CO2, right? Is that the point?
Correct. I mean, for your audience, the number one determination of your ventilation is CO2, not oxygen. If
Right.
your CO2 is high, it will drive you to breathe. If your CO2 is low, it will reduce your drive to breathe.
Got it. Got it. So a person in perfect health with an amazing airway and ability to breathe in their sleep would be somewhere in the 95 to 96 range, maybe 97, but not 98, 99, 100 in their sleep
Well,
with
no, no, no,
oxygen
no, no. In
saturation.
their sleep, it shouldn't be more than 95, 96. You
Got it.
naturally can. I'm talking about wake O2. Your wake O2 should not be, I mean, it'd be unusual. I mean, if you're 100, I would worry you're over breathing.
Got it. So I'm okay here. This is fine.
This is
My
fine. Yeah. Your
right.
oxygenation is fine. So this is more of the previous UARS type syndrome, we're talking about where maybe you have more arousals than hypoxia. In any case, the minimum oxygen saturation is 91%, which is fine. Like I consider like 89 or less more moderate. And so you're well in the mild category. So that fits the findings of the respiratory indices. The oxygen fits the respiratory too as well. Um, the mean, if I scroll down to the pulse stats, the mean pulse is 67. You see, can you circle that for the audio right there? The mean, that's a little high in my opinion. And I mean, it's in the normal range, don't get me wrong. But like in your 60s, it's okay. 50s is decent. 40s is, my gosh, you're in great shape. And assuming there's nothing else going on. And 30s is like you're an Olympian shape. So your mean
Wow.
pulse of 67 is just a little bit higher, right? I don't know. Do you work out, Ron?
I do work out. I run every day, and haven't been lifting recently. But I used to, as of 3 or 4 weeks ago, would lift 4 or 5 days a week. So kind of disappointing on that. Could that? So does this just mean that I have 67 beats per minute? So I'm bumping at a higher rate.
You're just,
My
it's fine. It's in the normal range. Absolutely no one will say that's abnormal. I'm just saying I read thousands of these a
yeah.
year, thousands literally.
Could this
And
be related to caffeine and nicotine use?
it could be. I think the main thing is for every one, there was a recent study showing that for every 1 beat increase in your mean heart rate at night, there's like a 3% increase in stress during the day. So I think, it's one of those parameters you want to look at is heart rate and heart rate variability. If you look over to the right, your minimum uh, pulse or pull rate is 48 and your maximum is 106. When you're awake, the range of your pulse is 60 to 100,
Mhm.
minimum 60, maximum 100. You don't want to be over 100 when you're awake and you don't want to be below 60 roughly. And then during sleep is 40 to 90. Okay. So it makes sense that someone with sleep disordered breathing will be a little bit elevated. Okay. Um, but I don't think those numbers take into account what your baseline heart rate is. Does that make sense? And so
Yeah.
if your baseline heart rate's a little bit higher, like for instance, 67, then um, maybe it's interesting. You want the pulse like your maximum. You want the pulse to react to your sleep disordered breathing. So you want it to go up. If it doesn't, but that's not ideal if it goes up because it's also indicating that you're, in stress. But if it doesn't go up, that could mean that you have reduced heart rate variability.
How does sleep disordered breathing affect pulse rate? Why would it affect pulse rate? Because the heart is working overtime to deliver oxygen to tissues?
Well, I think when you have an apnea or hypopnea, how it's terminated is with an arousal, and that arousal uh, and enables the airway to open. But it's also a time, and like as I mentioned, the peripheral arterial tonometry through the WatchPAT is there's also a sympathetic arousal that occurs at the same time. So your heart rate goes up, your blood pressure goes up, and it goes along with the cortical arousal. It's almost like a jolt, and depending on how severe the apnea is, and how significant the arousal is, there's a small or large jolt, so to speak.
So is that jolt essentially your body shaking you awake, saying, "Hey, wake up! You're not breathing."
Yeah, because like right now, you wouldn't have any respiratory events because you're awake. And so your body tries to recreate that wake like state with these mini micro arousals. The reality is you have these arousals that you have no idea that are occurring. And then, not every, I always tell people, hey, before you have a fire, you need a spark, but not every spark leads to a fire. Before you have an awakening, you need an arousal, but not every arousal leads to an awakening. But the most interesting thing is you don't remember necessarily every awakening. So, in other words, you have to have an arousal. That arousal may or may not lead to an awakening, and you may or may not remember that particular awakening.
And then furthermore, these awakenings disrupt sleep, to put it simply. They prevent you from entering certain stages of sleep for the appropriate amounts of time, and that's just unhealthy because we need to have sleep in a certain, arrangement and for a certain amount of time in order for our brain to be normal. Is that the idea?
Yeah, it takes. It's just like having arousals is like speed bumps on a highway. You want to get up to the proper speed, but you can't, and so it may knock you out of deep sleep. It may knock you out of REM sleep, deep by meaning slow wave sleep, but it also may prevent you from getting into those stages.
Hmm. Hmm. And it's amazing that the WatchPAT is able to catch these arousals. And I know we reviewed this in our last interview, but tell me where the establishment of sleep medicine is with respect to arousals. Do they take them as seriously as you do, or is this something that patients really need to be careful for? Is not having their arousals either not caught or misinterpreted as benign? Um, tell us about that.
Well, I think the establishment doesn't take RDI as seriously. They take AHI seriously.
Hmm.
Um, Medicare requires an AHI 4%, and now I think there's at least one major insurance company that's tracking Medicare criteria of AHI 4%, and um, but so I think one notch against you is that they're looking at AHI, not RDI. If they start looking at AHI 4%, clearly that's far fewer events than AHI 3%. And then it depends on the lab scoring it. The difference between the RDI and the AHI is, a hypopnea is a 30% or greater reduction in breathing with an arousal or a DSAT. You have to hope that the lab that you're working with is hand scoring those arousals, because the computers aren't necessarily great at catching the arousals. They're perfect at catching the DSATs. It's very easy for them to follow the line and see when it drops 3 or 4%, but they're not so good at maybe necessarily picking up an EEG arousal.
Yeah.
And so you have to hope that that lab has good equipment, and that the scoring technician is scoring those arousals with the hypopnea. Otherwise, they may not be counted as a hypopnea. Um, and and I think as I I'll mention, as I mentioned earlier, where's the arousal, right? It depends where they put the electrodes. Is the arousal in the frontal leads? Is the arousal in the central leads? Um, did they use dry electrodes, wet electrodes, paste? There's different levels of equipment and the procedure that will determine whether that arousal will be picked up in the first place. That's why I like the WatchPAT compared to pretty much most other sleep studies outside of my own lab, because I don't have to worry about that. The sympathetic arousal is very clean and easy, and it's universal. And versus the cortical arousal, which is very dependent on the score identifying it and the equipment that you use to detect it, and where and the type of location that you put that equipment on.
Wow. How is the WatchPAT catching sympathetic arousals? Which monitor is it?
It's the one on your finger.
And so how does that work? What's happening at the tip of the finger and in that monitor that allows them to detect arousals?
Well, I turn on my TV and the picture comes on. So I'm not sure if I can give into the technical. Like, I don't think I
Right,
fully
right, sure.
but
That's
anyway,
fine.
when it has, the watch pad has something on your neck, then that determines position. That's a microphone for snoring. And that also can somehow detect the vibration or whether or not it's a central or obstructive apnea. Then it has the thing on your finger, and you pull the tab and it inflates, and that can tell your heart rate, and that can tell, somehow, I don't know how it does it, but somehow it can tell if your arterioles and, constrict in that location. I just don't know how it does it.
Okay. Okay, but it has to do with arterial constriction in the fingertip. That's how it's detecting
Hmm.
RERAs or
Exactly.
arousals. Wow. Um, okay, so then big picture here. Do you think that I have a pretty serious issue here potentially? Does it all depend on my symptoms? I mean, what's the again the elevator pitch summary of my study here with AHI 5, AHI 3% 5, RDI 9? Where does this land along the spectrum? I know that where it lands along this colored spectrum here and with insurance companies, but to you personally, what's your perspective on this case?
I mean, I need more data. I mean, this study so far, and even just with the part that you've shown me, doesn't show me the whole picture. I'm willing to see the rest of the pages,
Oh,
but
sure.
it's mild sleep apnea, and as I said, it's one piece of the puzzle. And I'd need to know your symptoms. I need to have your exam. I need to see what your brain map looks like to see how this has impacted your brain. I need to
Wow.
see what your rhinomanometry looks like, your daytime breathing. I need to see the muscle strength in your mouth. I need to see the, your CO2 levels during the day. Are you over breathing? And there's different things I'd want to see, and then your response to those treatments if those are abnormal, and and then maybe we can make a judgment. But based on this alone, it's hard to say anything. Um, yeah, just alone, it's not easy.
Sure. Tell me about REM. One thing I've observed in my life is that I'll wake up in the middle of the night, let's say around 2 or 3 o'clock, and I'll feel amazing. Okay. And then I'll be up for 30 minutes or an hour. I'll read, I'll, scroll my phone, and then I'll go back to bed at 4 or 4:30. And then I'll wake up an hour or two later and I'll feel awful. Okay. That's when I'll have my headaches kick in after that second sleep that happens just before dawn and during dawn. That's also the time when I'm having really intense dreams. I'll often wake up from those dreams with the headache. It'll be a bad dream and something intense is happening. And then, boom, I'll wake up and I can have all this tension at the back of my neck. Presumably, that's the REM cycle, right? Because I'm dreaming. Is that wrong? And why is it that that stage of sleep causes a worsening of sleep disordered breathing?
Number one, yeah, typically REM is associated with dreams, but you do dream in non-REM. Number two, in a healthy person, just in general for sleep, when you wake up out of REM sleep, you are relatively alert. And that's because the EEG, the brain waves, are similar to that of being awake. When you wake up out of slow wave sleep, you're a little discombobulated. And that's
Hmm.
because the brain waves are similar, you have slow waves, you have delta waves. Um,
Hmm.
and so it could be as simple as that. It could be as simple as, hey, you woke up in REM and you felt good. You woke up in slow wave sleep and you feel discombobulated. Maybe we should make more than that. But we can see by your sleep study that you do have slightly more severe sleep apnea during REM sleep, and it's possible that you could be waking up, in a state of sleep disorder breathing, and that's why you feel a bit cruddy. So either
But
could be possible.
do many people have worse symptoms or have worse scores in REM sleep? Is that common? And if so, why would that be? What is it about REM sleep that does that to us?
Yeah, almost everyone's a little bit worse in REM sleep, but not always. The reality is you have, like smooth muscle and skeletal muscle. The skeletal muscle relaxes during REM sleep, and you have accessory muscles that support your breathing, and during REM sleep, those accessory muscles are lost. They're at you know they're and you're left with your innate muscles, I suppose, your basic breathing muscles, and those muscles can be compromised. They're not
Hmm.
adequate to keep your airway open.
Hmm. Hmm. You said here that I'm having some central apneas, right? You're seeing that here.
Yeah, a few.
Why would I be having central apneas?
They're normal. Everyone has a few.
It's not at all related to airway.
No. If you have like loop gain, high loop gain or whatnot, sometimes people could have transitional central sleep apneas where they go to bed and they kind of have a few centrals, but everyone has a few, and it's normal and it's healthy. They're called post-arousal centrals. So sometimes when you have an arousal, you overbreathe. And then with that overbreathing, you're knocking down your CO2 levels. And once again, CO2 levels drive ventilation. And if the CO2 levels are low, your body just says, whoa, take a break. Let's just not breathe for a few seconds.
Right, but then again, in that case, the central apnea is ultimately being caused by a non-central apnea, right? If we trace it back, the arousal is the
Yes,
the arousal is leading to excessive exhalation of CO2, which later causes a central apnea.
you're a good listener. Exactly. That's
Right.
actually 100% true. So if you do get rid of the obstructive events, the central events should reduce too.
Just the concept of central apnea has always boggled my mind. It doesn't seem like something that would be adaptive and that the body would just do unless there was some other malfunction or violation of nature that were occurring.
Yeah. Well, what's interesting is anything you do to open your airway, and that might be important for your audience, whether it's CPAP, BiPAP, oral appliances, nasal surgery, MMA, anything could potentially trigger central sleep apnea. And the reason why is you're ventilating more, and your CO2 level may go down, and your body may not be used to it initially, and then it may have some central apneas occur. But over, a month or two or three, hopefully they dissipate.
So it's essentially the body regulates itself and the
Hmm.
thermostat corrects itself and evens out.
Yeah. And that's what's important. If you're over breathing during the day, you're probably in many ways used to that environment, and probably over breathing at night too.
Hmm.
And so if you regulate your breathing during the day, over time, hopefully you can reset your thermostat, and then you can properly breathe at night too.
Is it too simplistic to say that the key to not exhaling too much CO2 is basically to just breathe through your nose all the time? Does nasal breathing act as a regulator of appropriate CO2 removal?
100% too simplistic.
Okay,
I
great.
would I would think that's accurate until I started measuring people with capnography. I would have agreed with you, Ron. Hey, just nasal breathing is enough. But we are seeing patients that are significantly hypocapnic, and they're breathing through their nose. And what's amazing is they look very calm. They look very, poised, and you would not. That there's no effort involved, and yet they're over breathing.
Hmm. Hmm.
And
And
so
is
what
this
we define is a normal CO2 level is 35 to 45 millimeters mercury. Mild hypocapnia would be 32 to 34 millimeters, and then moderate would be something like 28 to 31 millimeters, and severe would be like 27 or less. And so if I measured, if the patients that walk through our office, if 100 people walk in, I'd say about 40 to 40, 50 of them are hypocapnic. 40 to 50%, meaning that 40 to 50% of them are over breathing.
wow.
And among the 100, about 20% are severe. They're like 27 or less. So just, I know this, I mean, if you just, it's a little bit hyperbole, but if you just do this, or through your nose, you know, you're, you're going to feel kind of sick. It
Mhm.
doesn't take long before you feel sick. And that's what people are doing at baseline.
And what's the root cause of this overbreathing? Is it a mental health thing? Is it a is it just caffeine and other drugs that people are using without even thinking about it? Is it stress, which I guess is a mental health thing? How do we account for this? In nasal breathers in particular.
Um, I think it's behavioral. I think what happened is that this is my guess. I don't know, but it's something that you can control and change. So it must be behavioral. It can't be. But I think you have a small airway, whether it's nose, nasal obstruction, or small pharyngeal airspace, or transverse maxillary deficiency. And I think maybe you're panicked a little bit to some degree, and you're worried about getting that breath, so you compromise by taking extra breaths. And you can overbreathe by breathing 10 breaths a minute, or you can overbreathe breathing 24 breaths a minute. You could underbreathe breathing 10 breaths a minute, or you can underbreathe breathing 24 breaths a minute. So the number of times you breathe is irrelevant. It's how much air is being exchanged.
Right. Breaths are like cycles in an engine, but you could have a half-liter engine and you could have a 5-liter engine on a pickup truck, and you could have the same number of strokes or cycles, except one of them is moving a lot more air than the other. Is that the idea?
Yeah.
So you can't really count it as numbers of breaths. You have to also factor in, engine size, cylinder size.
Yeah. Yeah. And I think the big picture is that, your audience could do everything correctly. They could, widen their palate. They could do a jaw advancement. They can get nasal surgery done. They could do myofunctional therapy. They can they can take the medications for residual sleepiness. They can fix the brain. But if you don't fix that breathing, if you don't fix the behavioral over breathing, and I guess I'll just go on a small tangent. Why is that bad? Why is overbreathing bad? And if you overbreathe, you are constricting all your vessels. So when the CO2 levels are low, your body thinks, "Hey, I've got too much air. I got too much oxygen. I got my CO2. The CO2 levels are low. This person's overbreathing. Let me clamp down on my vessels." So you start constricting all your vessels, depriving all your organs of blood flow and the prefrontal cortex, most importantly. And on top of that, if you Bohr's principle, the lower your CO2 level is, the tighter hemoglobin binds to oxygen. And that's how oxygen is carried in the blood, through hemoglobin. And then it gets let go at the organs. But so not only does it bind tighter, the actual blood flow to the organs is reduced. And so you can get inattention, distractibility, headaches, high blood pressure, and whatever. It puts you in a fight or flight response.
Right. Right, right, right. And uh, could this phenomenon be related just to muscle tension, let's say at the back of the neck, which is something that people commonly complain of? Chronic tension in the shoulders and the neck. People waking up with that, for example, that's my primary symptom. I'll wake up with chronic tension at the back of my neck all the time. Could that be related to O2 CO2 ratios and how that affects muscles in local areas?
It could. I mean, it takes all of like. I mean, the thing is, oxygen is important for everything, and
Yeah.
so when the muscles don't have enough oxygen and doesn't clear out the toxins, you get cramps. So it could be. I mean, it takes 2-3 minutes to check. We just put on the cannula, watch them breathe, and that's it. But that's at rest, by the way. So we just test them at rest. We have a breathing specialist we work with, and when you do general activities, if you're hypocapnic just sitting there at rest, then you're most likely hypocapnic. It's more severe than it appears, but you could be normal at rest and still be hypocapnic doing the things that you normally do.
Hmm. And do you teach people breathing exercises that can help pull them out of this? Obviously, people are familiar with buteyko breathing, which I think is people really struggle to grasp what buteyko breathing actually is and and why it matters. Is that your go-to? Is McEwen and his buteyko breathing stuff, or what breathing lessons do you give people?
Well, we use a breathing specialist, and maybe I'll introduce you to her. Her name is Lisa Cush. She's amazing. And it's beyond me. I can tell you though, what you don't want to do is to go on the internet and just start doing breathing exercises like box breathing. You know, pause for 3 seconds afterwards, because the problem is you're replacing one dysfunctional breathing with another dysfunctional breathing. I mean, no hunter and gatherer does box breathing or counts to 3 at the end of expiration. Does that make sense? And so, I mean, so you don't want to like just, okay, I'm going to fix it myself. Don't do it yourself. No DIY here, DIY here. um,
Yeah, yeah.
so no, I just determine it and I pass it along to our breathing specialist, and then what we do is, and the other thing about your buteyko breathing, I think it's nobody should be doing any breathing exercises if their CO2 levels are normal. Like, what are you doing? Like, why are you reducing your breathing? If your CO2 levels are in a normal range, there's no point.
Yeah, you're fixing what's not broken.
Yeah, that's ridiculous. You might be making yourself abnormal.
Right, right,
So,
right.
it's crazy.
On this point, one other observation I will make is that when I was living at the Buddhist monastery in Valley Center, California, and meditating 8 hours a day and striving for these deep states of concentration called jhana, the characteristic of jhana as you ascend from access concentration, which is like a pre-jhana stage, through the first, second, third, fourth jhana, is that the amount of breathing that you do actually reduces as you go, to the point that when you're in the fourth jhana, you pretty much stop breathing almost completely. I mean, it's pretty bizarre. I never experienced that, but I experienced lighter versions of that where the breathing is really, really reduced. And at the same time, you have this amazing sense of bliss permeating throughout your body. And I wonder what the relationship between jhana and O2 CO2 ratios and just the pleasure that comes from proper delivery of oxygen deep into the tissues is. Did you have any thoughts on that?
I mean, I don't know what happened. I mean, the thing is, it'd be nice to have the data and have them hooked up and see what's happening. But like I said, optimal cellular respiration is between a CO2 of 35 and 45,
Mm,
ideally between 37 and 42. So you want to be at that 40 number. And that's when your vessels are just fully dilated and the cells are exchanging, what they're supposed to exchange with the rest of the blood and whatnot at an optimal level. And that's probably when you're fully, like, you'll notice, like, if someone is hypocapnic and they start reducing their breathing, they'll start noticing dun, 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 the pulsations in their neck first. And as everything starts to open up, they're going to be calmer
mm,
immediately. People start noticing they're calmer. They can feel the blood flow going. And to be in that state for long periods of time, which is what's normal, is unusual for these people.
mm.
And so maybe when they're that jhana, they're just ultra dilating their vessels.
Well, I guess that's what I'm suggesting, is that there's definitely some vessel dilation that's happening there. It definitely feels amazing. Why don't we jump back to some additional pages in the
Okay,
sleep
sure,
study?
sure.
Does that sound good? So
Yep,
that was page 3. Let's go to page 4. And again, this is my sleep study that I did 5
sure.
days ago.
So I don't really pay attention too much to the pat rest, the blue ones. That's just proprietary ones. But if you look at the orange, that's your snoring, and you can see that it's light, but I always look to see if there's clusters. It looks like there's small clusters. There's a cluster there, and then about an inch forward, there's another cluster. Another inch forward, there's another cluster. And then you can see 1, 2, 3, 4, 5, 6. But there's all these clusters basically, right? And so that makes sense because sleep disorder breathing usually occurs cyclically, right? It comes and goes, comes and goes, comes and goes. Um, and on the right y-axis, it's the decibels, and that tells you how many decibels that you snored at. On the right y-axis, 40, 46, 52, and so on. On the
Is
left
this is this just me as I'm falling asleep? As I'm
yeah,
like,
yeah, that's probably just noise as you're falling
okay,
asleep.
okay.
Oh, we don't know for sure, but that's probably. And then on the left is the positional data. And so that black line that goes through tells us if you're moving. So looks like in the first half of the night, you don't move that much. Maybe you're a little more restless in the second half of the night. Um, and there's no normative data for how much you should be moving. The next box is the oxygen and the SpO2, the oxygen saturation. And you should see typically you see some volatility of the oxygen that correlates with the snoring. And so if you look, kind of like generally, you can see, yeah, there's some correlation between that and the next cluster and the next cluster and the next cluster. You should be able to circle it with
I mean,
your,
look at this one right here, right? I've got this big spike in snoring and this big
yeah,
drop in oxygen, right?
yeah. But also, if you just like step back a little bit, you can circle that kind of 1 inch area. You can circle this cluster of snoring and the cluster of yeah, exactly. And then the one next to it, you see that how it correlates, and the one next to that, and the one next after that, and so on. And then you can see that it's not it is it positional? I think it is kind of a little bit positional, but you're on your back a lot during the night. Does that make sense? So you can see that in the supine position, which means your back, a lot of these occur. I don't see much occurring in the other positions, but you weren't in the other positions very much, right?
Yeah. Well, you know what I used to do, and I'm aware that I'm much worse when I'm in supine, which is to say on my back. So what I used to do is wear a backpack with two balloons in it to force me to sleep on my side. It makes it
Oh,
impossible for me to roll onto my back because I will just go to my back no matter how hard I try not to. For some reason, my body loves the back, being on the back. And yet I know that it's not good for me because that's when my wife tends to catch me snoring. And I tend to wake up from supine with headaches when I do. Um, so I'm aware of supine being problematic for me.
well, supine is the healthiest position. If you sleeping on your side is actually abnormal for too long because you can hurt your spine and whatnot. But the problem is if you have sleep disorder breathing, then sometimes sleeping in the supine position can worsen your breathing. Um,
Huh. Yeah,
and
so it's you're saying it's natural and normal for me to want me to be on my back. I mean, to the point that my body would rather be on my back and have sleep disordered breathing than be on my side and not, or have
yeah,
less of it, which is
yeah,
kind of insane.
I think we're used to the concept of sleeping on your side being normal, but really it's your back. And honestly, like, in the hospital, these patients that are kind of comatose, we have to move them every couple hours or so. I can't remember the exact time frame so they don't get decubitus ulcers. But really, you shouldn't move more than every, hour or two at the most, right? And then change positions and then change positions back just so you don't get an ulcer. I mean, your body
Right.
would naturally do that, right? But you should be mostly on your back, preferably.
I should also add, by the way, that this sleep study occurred on a bed that had a 6-inch incline. So the head of the bed was elevated 6 inches above the feet. So the whole bed is angled like this with my head
Mm.
up,
So
which
that probably helped your breathing.
I find that to be much more comfortable. I've been doing it for 7 or 8 years now. Um, but I would imagine that if I were sleeping on a flat surface, these numbers would be worse.
Yeah, but I wonder what your heart rate would be. Maybe your heart rate would be lower. I don't know because it has to work harder to get your blood to your head.
That's a good observation. So then, which is to say that it's not good to sleep inclined, or are you just saying that maybe we need a different sense of normal when we have an inclined sleeper when it comes to heart rate?
I mean, we don't know if these are
Yeah.
unknowns. That's why you track everything. But the ideal position is you sleep on your back, your head just gently bowed forward a little bit with a very, very thin pillow, which helps close the mouth. And then that's it. That's it. And there's nothing more to it than that.
Mm. Have Do you find, and this is kind of the $1 million question for me, right? Do you find that when people will go in and have a good jaw surgery that advances the jaws the appropriate amount, that they'll be able to actually sleep on their back comfortably and without having this kind of collapse of the pharyngeal airway? I know we're kind of jumping ahead here.
Yeah, absolutely. Absolutely. I do want to point out your pulse rate too.
Yes, maybe we'll circle back to the jaw surgery thing, but please go ahead.
Um, you can see that the volatility in the pulse also seems to correlate with the snoring and the oximetry. You can almost draw a long column for all of that, right? Going together, all the clusters. So all of these things we look at to help validate the sleep study. Hey, does the snoring correspond to the oximetry volatility, correspond to the pulse rate volatility. I will say that your pulse rate volatility, I mean, I just look at a lot of these, and some people's pulses really react well, like they're high, like they really jump up high in response to sleep disorder breathing. Yours is kind of low to medium. Does that make sense? So I would think that you have lower heart rate variability than maybe. Do you ever measure that?
No, no, I don't. How
Oh.
would I measure that with like a Aura Ring or an Apple Watch or
They
a
all have their
Garmin?
algorithms, but yeah, they all measure them pretty much, and it's just and heart rate variability is just your ability of your heart to react to a stressful situation. So, like for instance, when you inhale, your heart rate speeds up, and when you exhale, the heart rate slows down. And but some people don't do it as much, and they have less heart rate variability. Or when you see a danger and you got to run, does your heart rate just jump up, or is it just going to sit there at the same rate? Does that make sense? So it's your ability of your heart to react to various stressors. And
And
so
is it unhealthy to not have a is my heart rate variability too low?
I mean, that's no, it's not. It's there. I'm just saying. I see. I'm looking at a watch pad, right? So I don't know. It's not measuring it for me, right? But I can say that some people definitely have a lot more variability. So it's interesting. I'm not happy if it's too high. I'm like, oh no, the heart rate went up really high at night. But if I'm not happy if it's too low, meaning it didn't go up. So
And I'm on the lower end.
well, it just doesn't jump out. You see how your snoring kind of like spikes. You have these spikes in your snoring. You see that, the orange kind of like
Yeah.
good spikes. I'm not seeing those same spikes in your heart rate.
Mhm.
I do
Mhm.
see it, but they're more muted.
Yeah. And we're looking at heart rate here at the pulse rate, yeah?
Yep.
Mm. And is that it's not just because I'm a chill guy, right? It's it's something else, right?
You're not jawing during sleep. No. um, Yeah, and then I want to look at the wake sleep stages because that's probably a more telling thing for you.
Mm.
So normal sleep, just as simple as light sleep, deep sleep, REM, and that's one cycle, and you can circle that first cycle: light sleep, deep sleep, REM. You always count that, and there. The second
This
cycle
whole
is
cluster
yeah,
here?
that's one cycle. Next cycle is light sleep, deep sleep, REM, and that's another cycle. The whole thing from the very first cycle to the second. And then this next cycle is light sleep, deep sleep, REM. That's the third cycle. And then you had one more after that, a fourth cycle. That's it. So you had 4 cycles. 4 to 6 is normal during the night. And then, okay, that's great. And most of your deep sleep is in the first few cycles. Most of your REM sleeps in the second, your few cycles, and
That's
that's our
these big
second.
valleys,
Yeah,
right?
yeah, exactly. So your sleep architecture is more or less normal, the foundational part of your architecture.
Mm.
Now, but I also look at, hey, this how many times did he wake up within the time that he slept? And you can see that you woke up immediately after falling asleep once. And if you want to, yeah, there, and then later on, go 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. That's crazy. That's a
Wow.
that's a lot of awakenings. And then
Wow.
if you look at it closely, how many times did it take you out of deep sleep, meaning out of REM sleep or slow wave sleep? It only looks like the third REM, the third red one. No, no, not
This
that one.
one,
That one right
yep.
there,
Boom.
one,
That right
and
there.
then the second one right there too. So it didn't take you out of deep sleep. So you're lucky. It could have been worse. You could have a 12 awakenings, and they could have taken you out of deep or slow wave sleep or REM sleep. And that's not bad. But this is it's interesting. Some people have a low arousal threshold. Some people have a high arousal threshold, and um, and you can have some people with severe sleep apnea that for whatever reason they just don't wake up. They're just asleep the whole night. And you have other people like yourself with this mild sleep apnea, and maybe a little worse than REM, but you're just waking up all night long, whether you're in REM or not. Does that make sense? And
So I'm
it,
truly a light sleeper.
you're truly a light sleeper. The question is, could this be something else? Could this be periodic limb movements? Could this be something else that's arousing you? We don't know. We're making the assumption that it's respiratory, but your sleep is substantially fragmented.
Ghosts.
So, yeah, so in terms of sleep fragmentation, This sleep study is severe.
Wow. Wow. You know, and this is me not sleeping with my wife and baby, which I would
Mhm.
say that would double this, you
Are you
know?
wearing a CPAP?
No,
Are you
no,
no pot? Are you wearing a mandibular advancement device, nasal
negative.
dilators? Do you use nasal sprays before you go to bed?
I don't. No, all
Um,
natural.
and what you've done so far is an expansion, correct?
Correct.
No
It's
nasal surgery, correct?
no nasal surgery. No.
And and if you block one nose and breathe 3 times, can you breathe well? And you block the other nose three
Out of
times?
out of the left nostril, better. The right nostril is pretty bad, and right now, I don't know if it's allergies or just the heat kicking on and things being drier, but my nose is not great right now, but
Yeah, I know. I can hear it.
that's the good nostril, and then this is the bad one.
Hmm. I mean, they both
Mm.
sound a little tough, but
Yeah, yeah, for sure.
so what's going on in the nose? I'm sure you've had your own cone beam CT by now.
Um, I actually saw an ENT about a year and a half ago, and he wanted to do surgery. He said I had enlarged turbinates and that I had sinusitis. My these sinuses were full of infected tissue. Um, but then at the last minute, I bailed because I didn't. I got afraid of the empty nose syndrome,
Hmm,
uh, and that's just sort of where I left it. It,
hmm.
usually my nose feels okay, but uh, it has its limits. Like if I'm outside running or sprinting, just can't get enough air in through my nose. I can't. And then there's these periods throughout the year where I'll get all junked up, whether it's the dry season in the winter when the heat's on and the humidity is lower or allergies. Um, yeah, my nose is better than it used to be. The MSE helped, but there's a lot
Have you
to be
seen an
desired.
allergist?
Now,
You've never been tested for allergies?
not that I can recall.
Okay. Well,
Tell me, what do you think? You think this
typically
is
you
a big
treat
stone I should
medically.
turn
I
over?
mean, there you could, typically if you the most basic thing is to try Flonase for like 6 to 8 weeks. Try Astapro, an antihistamine spray, for 6 to 8 weeks, and
Mhm.
try saline sprays or rinses for 6 to 8 weeks, and then see how you feel at the end and do the same test. Just breathe through your nose each time. If that doesn't cut it, then I'd get a referral to an allergist and do formal testing for allergies. Do you have allergies to, maybe you have allergies to pets or, dust mites or something in the environment, and then I would try to eliminate those things. And if you need to go on immunotherapy, you can go on immunotherapy,
Mm.
and some more stronger. And if that doesn't work, then you would see the ENT, because what else do you have, right? But you have to restore. But I would back that up by doing rhinomanometry, getting some baseline data and whatnot. And then it's great that you have a cone beam CT, because you could track that along to see if there's actual improvement.
Can we scan through this CT real quick just so
Yeah,
I can get
yeah,
your
sure,
gut
sure,
take? So this is
sure,
with Dr. Rama at St. Elizabeth's in Massachusetts.
sure.
Um, it's only a minute and a half, but he's going to be scrolling through it. Maybe I can 2x it.
No, yeah. I mean, you can see the turbinates are enlarged already.
Do you have eyes on this?
Oh yeah, I can see it.
Okay.
I mean, the inferior turbinates are enlarged.
Where are you looking here?
Yeah, those two. I
Hmm.
mean, normally they'd be. I mean, what we do is we grade them grade 1, 2, 3, 4.
Hmm.
So 1 would be 0 to 25%. 2 would be 25 to 50% of the space, 3 would be 50 to 75%, and 4 would be 75 to 100. And we modified that through a visual inspection scale that ENT does looking in. And we just, because we have a CT, we're just assuming we're looking deeper than they can look, right?
Mm-hmm. Mm-hmm. And
So I
here's that.
call those a grade 3. Just we don't have all the angles, but grade 3, maybe a 4, but more like a 3. But still, anything over 2 is not good.
Mm-hmm. Mm-hmm. Yeah, and here's that junk in my sinus.
Yep, and you have some swelling in the other sinus too.
Yeah.
On the base of the other one.
Now, I did have a tad in the roof of my mouth at this point, and that could have been contributing to some potential. That's what I've been told. That could contribute to
Mm-hmm.
some swelling, but um, and then supposedly my sinus is completely blocked up here, like and unable to drain.
Yeah, you want to be careful doing an anastrostomy or anything. You don't want to do anything like that, ideally. Yeah, so you got some enlarged turbinates, but you haven't done anything. You're like a weed. You haven't. Have you done the spray protocols? You need to see an allergist. I mean, does that make sense? You're
Yeah,
fresh. You're so
virgin territory.
virgin territory. Yes, maybe a weed wasn't the.
It's
But
okay. It's okay.
so yeah. So you've tried Flonase, correct? I'm assuming.
No, never.
Never.
No.
Oh yeah, so for 2 months, just and maybe you can report back. I don't need to be on here, right? But for two, or maybe we do come back. I don't know. But anyway, for 2 months, just use a spray Flonase in the nose. One spray in the morning, each side. When you spray here, I just happen to have this. Do not spray up, okay? Because that's ridiculous. Spray in towards your ear, so you coat these turbinates, the inferior, middle, and superior turbinates. Does that make sense? Like you're shooting yourself.
Yeah. Yeah.
And so
Yeah. Yeah.
you want to spray in one side, one on each side, and then at night spray Astapro, because sometimes antihistamines can make you sleepy. So spray Astapro. It's over the counter. You can get all this on Amazon or wherever you want to get it. And then I personally just keep a saline, like simply saline extra strength in the shower, and I just spray the saline in the shower, and I kind of rinse myself out that way. And if you do
Mhm.
that for 2 months, I mean, you should notice some benefit. And if it's not enough, go see an allergist and get tested.
So if I do get benefit by doing that, then could that be a permanent fix, or does that just is that just a diagnostic that tells me that I should
Well,
permanently, reduce my turbinates?
it's controversial, but I prefer that you don't stay on Flonase forever. I do believe that the steroids do get systemically absorbed and it could cause bone loss and whatnot. So it's preferable you don't, but you could do it, 1 or 2 months a year.
Mhm.
And, but again, it would be nice to find out what you're formerly allergic to.
Yeah. And you said in the last interview that well, let me just jump on that for a second. Find out what I'm allergic to. So, how have humans survived all this time if they're just going about these environments that they're allergic to that's causing their bodies to malfunction? I mean, what's the deal with allergies? What's that really all about? Are we just weaker and more sickly these days, and so we're more affected by allergens, or what's your take on that?
Well, I think allergens, I mean, it's not natural. We're in it's not natural for us to be in a home in one location. It's not natural to have rugs like what's behind me. It's not natural to be eating food out of packages and,
Mhm,
wrappers and whatnot.
mhm.
And so it's pervasive. It's everywhere. And the sad thing is you can do all this allergy testing. They can light your back like, like prick it all the way across like you're being tortured. And but they're not testing for everything. There's so many things out there that they can't even test for. And but it's an unnatural situation that we live in. But unfortunately, that's it. You're going to move from one home to another home to another home
Yeah, yeah, that's interesting. Um,
and eat packaged food at some
right.
point during the
Right.
day.
Right, right, right. Yeah, not to mention, microplastics and all that. Andrew Huberman just did a really
Yes.
terrifying episode on microplastics.
Yeah, I hate. Yeah, I mean, I didn't watch it, but you wonder if all that breast cancer and everything else is from microplastics, and being, I don't know, who knows?
Yeah. It makes me feel like it's only a matter of time until all of us get cancer, you know? Like we're
Hmm.
all just fucked basically, you know? Um, between microplastics and all of this radiation that's in the air everywhere. I mean, I don't want to go too far down that path, but our environment is totally unnatural. You're right.
But in a good sense, maybe we'll mutate into something different.
I think that's optimistic. I think that's optimistic. I think maybe we
Bring it
can
on.
just maybe hopefully, cancer medicine improves at a faster rate than we're all, intoxicated with this
Yeah,
stuff.
yeah.
Um, all right, is there
Okay.
anything more we can
Yeah,
see
let's
in this?
let's let's go to that next page on that
Hang,
watch pad, and we can,
hang tight.
go through your case and
Next page here.
yeah. Yeah, so this page is interesting. I'm just going to look at the PRDI in the body position stats. So you're not really worse on your back than your non-back. You notice that you're 9.1 in the supine position, and in the far right, you're 8.5 in the non-supine position.
Mm,
Do you see that? So it didn't
mhm.
really matter, but this gives me clues. Look, I'm trying to milk as much as I can out of this WatchPAT report for your care, because that's all I got.
Thank you. No, thank you for that.
And so what it shows is that your right and left side, there's a discrepancy. You're 12.6 on your left side and you're 5.4 on your right side.
Hmm.
You notice that?
Yeah.
And so what that means is that if you're, what that would probably mean is that your right side is blocked, right? Correct?
Yes, the right side is the bad side.
Yeah, and so the reason why your numbers are better on the right side is because when you sleep on the right side, you're already blocked on that side, and then gravity blocks it more. So whatever, it's a small loss. But your left
Mm,
side is open and stays open. But when you sleep on your left side like that, now you're blocking your good side with gravity and fluid and whatnot. And now the right side is bad to begin with.
wow.
And so now you're blocking both. So based on this, if you just said treat this patient, you cannot see this patient, you cannot do anything with this patient, but look at this watch pad, I'd say go to an ENT and fix your nose.
No kidding, huh? Wow.
You like that?
Um, yeah, I love that. I love that. You know what's the worst part? The worst part is, isn't it weird how when with couples, like you get fixed onto a certain side of the bed,
Oh
and
yeah.
I'm the right side of the bed, so I prefer to sleep on my left so I can face the overhang of the bed where it's open and clear. And so that's the bad side for me to sleep on. That's my left. Because if I sleep on my right, then what happens is my little baby daughter kicks and scratches at my face all night. So
Yeah.
I'm just screwed.
Yeah, 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 yeah. Or you can get a good nose doctor and fix it. Yeah.
True. Or my wife and I can switch.
Yeah, oh
Um,
yeah, that's easier.
um, but okay. So when you say fix my nose, could I unilaterally fix just the right side of my nose to hedge against a total botch? Is it not
No,
rational for
I
me to be
think
afraid of a botch? What's
I
the
think no,
deal?
I think I mean, that's I would think I would basically go back to what I originally said. Fix the allergies first if you can medically.
But doesn't that amount to like a lifetime of being on some medication, basically, that's going to have its own side effects? Can
Um,
I just go right for the mechanical fix to just make the box bigger?
well, you can. I mean, you could do spreader grafts, and it depends if the obstruction is on the inhale. If the obstruction is on the inhale, then it's due to the nasal valves collapsing. If the obstruction, that's why rhinomanometry is helpful. If it's on inhale, it's the nasal valves. If it's on exhale, then it's something inside, like the turbinates or some other, structure. Um, does that make sense?
Yeah,
And so, if it's on inhale, then I'd say hey, go get spreader grafts. Where they're called nasal spreader grafts, and they prevent the nasal valve collapse. Or you can just wear breathe right strips or intake magnetic breathing or mute nasal dilators, right? But
I've
then
tried all those things. I like all of that stuff.
yeah, the problem is they put an abnormal tension on the cartilage. And, for adults, maybe it's not a big deal, but for kids, I'm always a little wary. I don't want to damage the cartilage long term
Or reshape their nose.
or reshape or just, I'm sure, we all know it in the whole ortho field. Small forces over time have large impacts. So, but I
Yeah.
like it as a test.
Right. Right. I used to wear those nasal strips during my exams so that I could breathe better and stay
Hmm.
on my game during my exams.
Yeah, yeah.
Um, wow.
Like
Okay.
when you breathe in quickly, does your valves collapse?
I don't know. Let's find out.
Get close to the camera. Yeah, they do a little bit. Yeah, yeah,
Yeah.
yeah. I mean, they do. So, but once again, if the turbinates were small, would they still collapse? That's so. If they still collapse with the turbinate small, then you would probably benefit from spreader grafts.
How do I find someone to do spreader grafts?
Any good rhinoplasty surgeon can do it, right?
Really?
Number one. But then it's very difficult to find a routine, I say routine, a non-cosmetic ENT to do that. It's an old school. They either take cartilage from your own, septum or your rib, or they take cadaver cartilage or whatever, and they gotta lay it on there. And sometimes if it's not done right, it's kind of wonky.
It looks
when
bad.
it can, but like I said, there are some that do it, but a lot of them that do that, it's more cosmetic. But anyway, they call it spreader.
Do you have someone you can recommend?
I mean, the people that we use here in Northern California, the I use Dr. David Kim in San Francisco. I use Dr. Sam Most at Stanford, and you can see their galleries before and after. In the insurance world, that takes insurance, I use Dr. Michael Freitas at UCSF. He does those spreader graphs. So anyway,
Hmm.
you can find them, but yeah, it's hard. You'd have to ask around. Not most ENTs don't do that. I'm not
Right.
saying you need that.
No, I know, but
But remember, in the facial fifths, the width of your nose should be the width of your eyes, and so a lot of times people get used to a more nasal, a narrow nose.
mhm, right.
I can see your mind churning.
It's a lot to think about. Um, big picture again, you're seeing here that my issue is not necessarily just a pharyngeal airway issue. There's definitely a nasal issue, and that you're gathering that from the fact that my non-supine RDI is almost as severe as my supine RDI. That's
Yeah,
closing the
yeah.
weave.
Like MMA would be low on my list. Looking at this WatchPAT, if I had
Mhm.
not, even if I had not seen you.
Right. Um, that's interesting. That's interesting. I have my To be honest with you, I'm strongly considering doing an MMA, and I'm gonna be meeting with some jaw surgeons soon. But the reason I'm wanna do MMA, and I wanna get your take on this too, maybe this is a little bit outside of your wheelhouse, but while I have you, I do wanna ask, hang tight here. The reason I wanna do MMA is not for sleep disordered breathing, but because I feel like my tongue needs to come forward a certain amount in my mouth in order to relieve tension at the back of my neck. And I've actually been experimenting with this hypothesis the past 2 months, where all the time throughout the day, I'm basically just sticking my tongue out. Like if I'm working on the computer, walking around, exercising, I'm like this. And I find that that relieves tension at the back of my neck, and my headaches have gone down almost to zero since I started doing that. So I think it's a neuromuscular thing where there's muscles that are connected to my tongue and also at the back of my neck, where as my as those muscles hold my tongue into my mouth and my tongue isn't able to just relax, it's causing excessive muscle tension at the back of my neck, and then maybe with some aberrant nerves at the back of my neck, maybe some extra branches on the lesser occipital nerves that are running through those muscles that are being overused. The nerves are being squeezed, and they're maybe wrapped up in some scar tissue from permanent overuse of those muscles over a lifetime, and that's what's causing my headaches. And, just releasing my tongue, relaxing it forward is relieving that.
Oh, okay. Listen, snore for me. Make a snoring noise. Like, no, like snort, like a piggy. Okay, now do this. Bring it forward. Now can you snore? Okay, yeah. So maybe, listen, maybe an advancement would help you. I mean, I'm not, that's my cheap test.
I
You
think it's
can
a
probably
great test
probably bring it forward 4 or 6 millimeters doing that. But the thing is, but what's your goal? I
to
guess
have no headaches.
you might get that with the nasal procedure. Typically, I don't, uh, I always say do the nose last, but your numbers are mild and your facial aesthetics look nice right now. Turn sideways.
They're all right.
Yeah, and you got a good jawline. I mean, you're a little recessed, sure. You could use a little bit. Maybe, yeah, I take it back. You can use a little bit, but who can't? Does that make sense? I mean,
Yeah, but not everyone has chronic headaches.
yeah, but maybe you're overbreathing. Maybe, maybe maybe
But
it's
why?
not.
But why does sticking my tongue out cause the headaches to go away? And I can actually feel this immediate release of tension at the back of my neck.
Mm,
How else would you account for that other than this being a, you know, chain reaction of muscles that are connected to the tongue?
yeah, but if I stick two Q-tips up your nose and pull it wide open, would the headaches get better? I mean, I'm just throwing it out. Like no.
No, no.
Yeah, what's your minimum pharyngeal space in the back?
I don't know, but last time I looked, I remember that the conclusion was, "Wow, Ron, when I looked at you, I didn't think it was going to be that bad, but it's worse than I thought."
Okay, then do another test. Take your jaw,
Yep.
open it, and push it back down.
Mhm.
Does that block your breathing?
Yeah.
Yeah. Okay. All right then. Well, it's interesting. Aesthetically, you look okay. Does that make sense? But yeah, I mean, based on those simple non-validated tests,
Yeah.
it seems like you could use a little bit of an advancement. But gosh, like I said, what's your goal? What are we trying to achieve? And what's the minimum, the least invasive way of getting there? Um,
Mhm.
and that's
Mhm.
hard to tell, right
Mhm.
now,
Yeah.
because jaw surgery is pretty significant, and you haven't even done allergy treatments yet.
Right. Right. Yeah, I guess it's all just coming down to this belief that I have that it's a muscular thing, not a breathing thing. You know, um, that even if you could pump the perfect chemistry into my body, if my mouth were closed and the tongue were held back and these muscles were activated, I would still have the headaches.
Have
That's
you worn an oral appliance, like even a boil and bite, like a my tap, that for like a week or two, to see if that makes any difference?
yes. Not one of those, but I've worn a tongue stabilizer that pulls my tongue out of my mouth in my sleep. Have you
Oh,
seen those?
the Avio,
It's a cheap
Avio.
one off eBay. It's just
Oh,
a
okay.
little suction cup, and
Yeah,
you
yeah. And
and
that
then
help?
it helps a lot. Helps a lot.
Well, yeah. I mean, if you're treating the headaches, have you seen a neurologist too? I
Oh,
guess.
I've been seeing neurologists my whole life.
And do they do any? Okay, yeah.
No, they
No
don't do anything.
SPG blocks and.
They just refill my triptan prescription. Oh, blocks like nerve blocks?
Yeah, well, they can do nerve blocks through the nose and inject lidocaine and whatnot. Anyway,
Well, I've had 3 migraine nerve decompression surgeries. I've had surgery at the back of my neck and my eyebrows and
and,
temples.
and but does a CPAP get rid of my headaches?
Um, no, it didn't when I used it. It didn't. I felt better. I think it was improving the sleep disordered breathing, but it did not really help the headaches much. I would still wake up with the neck tension.
So I don't know if that MMA will result in your headaches getting better then.
But again, if the CPAP is just forcing air, but my tongue is still constricted, and those muscles are still being activated and overused and pinching nerves, then I think logically the MMA surgery, which would relieve the tongue, could still help.
Yeah. I mean, there's data showing that patients with sleep apnea, their muscles are still in use during the daytime to help keep their airway open. And the thought is that at nighttime, they just wear out because when they're actually needing to be used, they give up because they've been working all day, versus someone who doesn't have sleep apnea may
Right.
not need to do that. It's a tough situation because you're not necessarily targeting the traditional symptoms of sleep apnea. I mean, you're targeting one specific symptom, which is a headache. Um,
Correct.
I guess, do you, I mean, do you wake up to use the restroom at night?
All the time. And I wanted to ask you about that. I wake up 3, 4, 5 times a night to use the restroom sometimes.
Do you drink water at night?
Very little. I have to restrict it. Otherwise, it's just ridiculous.
Do you grind your teeth at night?
Sometimes I do.
Do you
Yeah.
drool on your pillow?
Yes.
Is your sleep kinetic? Do you move a lot that you're aware of?
I think so. Yeah. Yeah.
But does CPAP stop all of these things?
I haven't used it in 6, 7 years, to be honest with you. I don't remember. I still have it. Maybe I should bust it out.
What about BiPAP?
Never tried it.
Never tried it. It may be. I mean, I think you should do. I mean, we can't come up with the exact guidance here without more testing and
Yeah.
whatnot. But might be maybe good to back up a little bit because I think you're headed straight to the ENT, straight to MMA, and I don't know if you've done some of the pre work. It's good. It's exciting.
The pre-work is you're right. But I've done a lot of pre-work though. Done a lot of
Yeah.
pre-work. Maybe not those specific things, but
Yeah.
I just this it's again, I just come down to this fact that when I stick my tongue out for 17 hours a day, the headaches go away. And it's to me that's like the smoking gun. I'll tell you how I realized it too. I was working out and and I I was doing pull-ups and I stuck my tongue out and then I immediately felt this huge rush of improved ability to breathe, and then also release of tension at the back of my neck. Like literally, there's like some direct link between my tongue being out and the muscles there relaxing. And then I was like, what was that? And then I just continued to replicate that for the past 2 months, and it's like not a placebo. And I've been asking lots of different people to help me come up with a mechanism to explain what's going on, and no one's ever really heard of anything like it, even though tons of people that I talk to have chronic neck pain and headaches. So I think I'm not totally alone with this
Hmm.
potentially being related to tongue space. Um, but then sometimes I like talking to you. Does make me feel a little crazy, like I'm really out on a limb here.
Well,
I
I'm just saying that you're expecting the surgery to cause a specific outcome. It may not cause that outcome. That's what I'm saying. But if you're okay with, it'll help your breathing no matter what to some degree. If it's done properly, it should aesthetically be pleasing, and it should be good material for the show. I mean, if anything, right?
right, mixing business and pleasure, so to speak. Um, No, I hear you. And I think I would be foolish to not acknowledge that it's definitely not a slam dunk, and that's why I'm going to be consulting with so many surgeons, is to see what the consensus is. If they all tell me I'm crazy, I'm not going to do it, obviously. If
Yeah.
no one's willing to do it, I'm not going to do it,
Yeah,
you know?
well, I mean, I think you should explain. Yeah, I'd be curious to watch those shows too, with each one and get their opinion. Anyway,
Yeah, no, for sure. And I'm next week I'm seeing Dr. Gunson, Dr. Wallin, and Dr. Bell, and then at some point I'm going to see Dr. Alfie too. Those are my. I don't know Dr. Wallin, but I know Gunson, Bell, and Alfie, and I just want to see what they have to say.
Sure, sure,
You
yeah.
think that's a decent?
That's fine. Yeah, I think it's good. I think, like I said, it'd be nice if you had some of the preliminary allergy testing, and you can maybe see some top, nose surgeons, and whatnot, right? And then get,
Yeah.
this way you can, but that won't explain your tongue, right? And so if you're set on that, then yeah. And if anyone has the capnography unit, if they can just hook you up for 3 minutes and you can just kind of watch yourself breathe, that'd be great.
To determine if I'm overbreathing.
Yeah, because then that can be a cause for your headaches. I'm just trying to point out things that maybe you just control your breathing and maybe that'll get rid of your headaches.
Yeah. Yeah. All right. I'll also look into that too. I appreciate you weighing in on that. Should we jump back to the sleep study and maybe see what's left there?
Yeah. I mean, the rest of it looked okay. You can put it up, but your deep sleep and light sleep, REM sleep was 18%. Actually, I take it back. It is a little abnormal. If you go to so you over 60 decibels in the snoring stats, you do snore loudly, 1.9 minutes. So about almost, 2 minutes that you snored above 60 decibels. That's where at least some of the ordinances for leaf blowers that you had heard earlier in the broadcast in the background of here,
Yeah.
that you couldn't be above 60 decibels. So if that bothered people, that's like, you're snoring there, for a couple
Wow.
minutes. And then,
Wow.
the REM sleep, on the bottom is 18.92% in the chart, the pie chart. That should be normally 20 to 25. So you're a little bit lower, but your deep sleep was great, 26%. So maybe it's a little compromised your REM sleep, but not much. But overall, the stats are pretty good there.
Mm-hmm. Mm-hmm. Yeah, my wife is waking me up all the time telling me I'm snoring.
Yeah, yeah. So I mean, the WatchPAT tells us a lot, but it tells us your nose is more of a culprit for your apnea right now,
Based on this line right here.
based on that line right there.
Mm-hmm. Unless I sleep on my right side.
Yeah, you sleep on your right side, but then that's going to hurt your spine. You can't be sleeping on your right spine forever, right? That's
Right.
not normal.
Exactly. That's not sustainable. Okay, so the informal prescription here is allergy testing
You
first
can
and
try
foremost.
you can try over-the-counter treatments if you want on your own for a couple months, and then you can go get formally tested, see an allergist, and get formally tested and treated. And then, if you're going to do MMA, if you're set on it, then you would do the nose after if needed.
Mm-hmm.
um, and if it's still needed after the allergy treatments. And if you're okay not doing MMA and just trying something, I mean, a nasal surgery is aggressive too. It takes 3 hours sometimes, right? But that would be the other option if you're going to do it surgically. And then obviously other things like checking the tone in your airway. Like we don't know what your left lip, right lip, front tongue, back tongue strength is. We don't know what your CO2 levels are, as we mentioned, right? When you're daily breathing, there's there's other things we don't know, and so it'd be nice to go through some of that.
Yeah, and that's all things that you do in your clinic as part of your full workup. This WatchPAT is just the tip of the iceberg, really, huh?
Yeah, that's what I said. So we take this, but I would have the luxury of seeing your brain map and seeing how impacted your brain is. I'd have the luxury of seeing the rhinomanometry and if it's inhale or exhale and how much resistance there is. I'd have the luxury of the CO2 levels of your daytime breathing and the muscle strengthening. And yeah, tell you to do all this homework before you broke your jaw or, did
Yeah,
nasal surgery.
yeah. Yeah, that's incredible though that you do all of that. And so when someone becomes your patient, basically they come out to California, and how does it go? Because presumably all of this testing, if, especially if there's sleep testing involved, would take more than one day, right? And at least
No.
one night.
Well, if there's no, if they do a sleep test, yeah, they had to spend a night. But other than that, we do all the testing. We don't do a cone beam test typically unless the person hasn't had one, and then we'll add the cone beam CT too.
Is that just because of radiation?
Well, no, a lot of our patients already had it. Like you've already had it, but unless you're just really old and you want an updated one,
Yeah.
we don't normally include that in the initial visit. Um, and we have the Plan Mecca G7, which is nice. It's the latest cone beam. The biggest sensor captures the entire airway from the frontal sinus to the epiglottis.
Really? That thing sounds like it's probably worth a couple $100,000, right?
Yeah, well, it's like cone beam CT porn, I guess.
It's funny. It's funny because on my last episode with this peripheral nerve surgeon that I talked to, we did like MRI porn where he was telling me about all of the latest and greatest in MRIs and how they, there's MRI strong enough that they can see individual like blood vessels and nerves now, and it's like MRI technology is
Yeah,
getting a lot
there's
better
like
too.
you're right. I think it's 10G or something crazy, and
He
it's
was
a
telling me about a
beautiful.
15 one.
Yeah, yeah, it's amazing the definition they can come up with now. So this cone beam will be archaic, I'm sure, in 5, 10 years, but it's good right now.
You sell it on eBay.
Yeah, 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 yeah.
Um, all right, doctor. Uh, what I know we're running out of time here, and you probably want to go get ready for work. But what should one look for in allergy testing? Like, what are the big key things to look out for to make sure you're not getting um, some crappy superficial testing done? How does one go about that?
I think the pinprick testing is better, the one on your back, than a blood test, unless the person can't tolerate it for some reason. Um, and Yeah, I think those are I mean, it's really, some allergists will say, "Oh, I poke in harder than others," right? And then they're more likely to find the allergies. If you have allergies to a lot of different things, or if you have a lot of sinusitis, which you didn't have, but if you have a lot, sometimes they check you for immunoglobulin deficiencies, and so other things. Um, so I mean, hopefully you just find one with a good reputation. But
Hmm.
are you hyper flexible? Like if you push your fingers back, does it bend back really far?
I'm not. No. Are you thinking EDS?
Yeah, yeah. I was just wondering. So just
No, I'm not.
okay. All right, good. So yeah,
Nope.
yeah. No, no, you're good. You're good.
What? How does EDS factor into this stuff? It just makes everything floppier.
Yeah, that's pretty much it. Down
Mm,
syndrome, people are hypertonic and can have more likely to have sleep apnea. Um,
yeah. Um, when you see someone with a nasal breathing issue, potentially like me, do you ever see them skipping all of the nasal stuff, going into MMA, and then MMA has a positive impact on the nasal breathing, just in virtue of
oh
kind
yeah,
of.
yeah,
So MMA
absolutely.
is a kind of nasal breathing treatment too, isn't it?
Absolutely. If you open up the restriction in the pharyngeal space, you're going to breathe better through your nose.
Yeah. It's just um, the most invasive thing you could possibly do, I guess. There's other things you could do first. Another thing I've learned about since I saw you last is Dr. Alfie does when he's doing his surgeries, he does a like this periform rim shaving where he'll remove bone here.
Okay. And make it larger.
Yeah, what do you think about that?
I never heard of that actually. That's
Yeah,
interesting.
because he
I
says a lot of patients that need MMA have these, excess bone in this area, and he will just take his saw and he'll just and then take off a chunk of bone right there.
Yeah, that's interesting.
After he drops the maxilla. The maxilla's
Yeah.
already dropped at that point,
Um,
and actually plated, I believe. It's already fixed in its new position, and then he hits it, if I remember correctly.
I mean, I think it's going to be a little early to tell. I mean, as long as he's seeing good results and nothing bad is happening, but he's only been doing it recently, right? So I don't know. I'd let someone
Wow.
else do it for a while and then see what happens later. Maybe in 5 years, make sure there's no like bone degradation of some type. I don't know. Like it seems like they're weakening it, but it should. I don't know. That's just hard to. I just never heard of that, so I
Mm.
don't want to comment on it.
Mhm, mhm, mhm. And then if I were to ever pursue a turbinate reduction, What's your thoughts on the best way to do that? The ablation, the scalpel? Where do you land on
I
that?
mean, I think either radio frequency, which you may have to repeat, or the submucosal resection. I think those are the two ways to go.
If you were doing it, do you have a surgeon that you would use for that? Is it important, just like with MMA surgery, to really there's only a small select number of ENTs that are really
I
good at
mean,
that?
yeah, like for radio frequency, I think the best is probably Jerry Hester out in Menlo Park. Jerome Hester, he does. I think he's been doing it for 20 years.
Wow.
So, and you can do it in the office or you can do it in the OR, but you have to numb it up, so you can't get as much in the office as you can in the OR. Um,
Yeah.
so I
And you
kind of
s
pick and choose. Does a person want to go through insurance or not? Does a person want a more cosmetic effect? Does a person just want to do it in the office? So I kind of pick and choose my surgeon based on that, and
yeah.
locally at least.
Yeah, but you said with the radio frequency ablation, that has to be you have to mow the lawn every once in a while and come back and
Yeah,
hit it again,
yeah. Unless you fix the allergies,
unless you fix the allergies. Wow. And are allergies things that can be cured, or is it just something you can consistently treat, like with a
just consistently treat, suppress,
you gotta just
avoid.
pour pesticide on it?
Well, if you can avoid it, you avoid it. Like if you're a cat allergy, don't have a cat. But if it's something else, then you may have to just be on immunotherapy.
Mhm. Got it. All right, doctor. Why don't we wrap there? Thank you for helping me out with my sleep study. Thank you for sending me the WatchPAT in the first place and agreeing to do this, and for all your time today. By the way, our last podcast, people loved it. I'm sure they're going to love this one too. And if people want to become your patient, how can they do so?
Oh, I mean, just go to the website, sleepandbrain.com, click on book an appointment, choose a location, and pick initial office consultation. And I just have to remember that I only have a cone beam CT in the Saratoga office. I don't have one in the Menlo office. So,
Okay. All right.
but,
Yep.
but
That's
that's simple as, or they can call me. They want to talk about their case, and see if they're a good fit and whatnot.
sounds good. All right, doctor. I'm grateful to have been your patient today, and
Oh my gosh. I would, if you're ever in Northern Cal, I'd love to do the testing on you. If you're ever in Northern Cal.
would you be willing to help me out with that
Yeah,
and
sure.
treat me?
Absolutely.
I would love
Absolutely.
to. No,
Yeah,
I would really like to do that
100%. We
testing.
could run through the tests and then see how it is.
Okay. All right. Really appreciate that. We'll definitely do that at some
Before
point.
you break your jaw or anything.
Yeah. No, I know. I know. I know you had your own MMA surgery, so you know how tough it is to go through that. And
Yeah.
that's why I take it seriously when you say it to me, because you come from a place of empathy and not just from a place of, oh, MMA is
Well,
tough or whatever.
I mean, no one sees the downside, the numbness, the things that can go wrong. And you only see, hey, my tongue's gonna be more forward, I'm gonna have less headache. So A, you may not get that, and you may get the negative outcomes.
Yeah. And if I look better, that doesn't even matter because I'm already married, so I'm out of the game anyway. So who cares, right?
Yeah, yeah. It doesn't hurt though.
Actually, my that's the number one reason my wife is against it. She doesn't want me to look different. So
Oh, really? She
she's
likes
the
the way
number
you look?
one block to the surgery right now. I mean, she married me. I think she likes the way I look.
Yeah, she'll be
She definitely didn't marry me for my money. I can tell you that.
yeah, she might be a little threatened by your new strong profile.
Oh, I know. I never
But
thought of it like that.
ultimately it's healthy for her though, right? Like,
Definitely.
like
Definitely.
it's good to, okay, he's still safe to be with, and then she'll mentally be stronger.
Right, that's pretty based, but yeah, that might be that might be what it is.
Yeah, she probably sought you out because of her insecurities, or she wanted someone with a slightly weaker profile that
Oh,
she thought
man,
she
I
could
hope not.
dominate.
Oh, oh, man, that's
And
brutal, doctor.
you've slowly turned the tables on her. You're healing her. You're doing all your surgeries are therapy for your wife, because
Oh, man.
now she's used to the strong. I haven't met her, by the way, whoever this is. But now she's used to the strong facial profile, and it's ultimately good for her, like
Oh gosh.
a
I think
strong featured person should end up with another strong featured person. But what often happens is a strong featured person preys on the weak, and the weak appreciates the strong, but ideally they're both strong.
well, my wife does have a very sharp jawline, so
Yeah, there you go.
I think you
But
may be
now,
right.
but you are becoming the man she should have always sought from the
Not
beginning.
not until this surgery is done, doctor. I need the surgery to complete the project.
For your marriage, I suppose. Oh,
Oh
okay.
man. Oh
We should
man.
probably end it there.
All right, doctor. Hey, thank you so much. I appreciate it. Okay,
Okay,
we'll be
hey,
in
hopefully
touch.
we'll see you out here sometime.
Okay, thank you.